Okay, so we were doing this kind of research because we know that many Filipinos have osteoarthritis. And particularly, they suffer from the affliction. And many take oral analgesics when pain becomes unbearable. But most of this drug intake would have an impact on some of our organs. So they cannot really take it continuously because of some end organ diseases that might happen. So when the pain becomes unbearable with the possibility of serious side effects, it's quite difficult to continue on taking drugs. And then, next slide please. Okay, so it can also cause a financial drain on the patients, particularly if they come from poor families, because we know that the cost of drugs are quite expensive, and if their income is not so good, then it's really a drain. And most of the time, they just suffer. So no drug intake, or if they eat the drugs, it's they take the consequences. So our aim was to provide an alternative to drug intake for pain and other symptoms of osteoarthritis of the knees among Filipino patients. Okay? So why LLT, or low-level laser therapy? Because various studies have shown the effectiveness of the LLT on various occasions. There is an improvement of pain and morning stiffness in rheumatoid arthritis among patients, and this can be found in a lot of studies already. And there is also an improvement of pain and the microcirculation in patients with knee osteoarthritis. So we were thinking that we could practically do that. And then there's also light tissue interaction that would lead to analgesic effect. Earlier, Professor Mosbin was talking about anti-inflammatory reactions with the use of low-level laser therapy. So a meta-analysis showed that the affected joints had reduced pain in patients when the laser was applied. Okay. So the advantage of the low-level laser therapy was that there was no known side effects or adverse reactions. And it was safe and non-invasive modality. And of course, it was cost-effective after you have bought the equipment. And the patients would usually not buy the equipment. The institution would buy it for them. So they can just come and have it for treatment. Okay, so it's also easy to apply. The equipment is very user-friendly. It's very portable. It's very light, as what the sample outside shows. You can bring it anywhere. So we have been traveling carrying that kind of equipment. I think it's only 800 grams. It's even less than 1 kilogram of rice. So there were questions on the LLT application. Are we going to use continuous or pulse mode of delivery? Or are we going to use the different wavelengths? Is it 808 to 904? Or would the treatment be applied locally or over the nerve paths? So these are the questions that we had to address. And should we use a higher or lower output? Treatment duration, what should it be? Range from 2 weeks in some of the literature that we noticed to 12 weeks and 200 seconds to about 10 seconds. So we were trying to look into being the alternative or conventional unconventional medicine specialists that we were also on traditional Chinese medicine. And so we thought that if we use laser on acupoints, would it give relief? We were trying to come up with establishing a regimen for osteoarthritis. And we know that the TCM, or traditional Chinese medicine, would define osteoarthritis in a different way according to their own explanation. So they called it the B, painful B, which is described as severe stabbing and fixed pain in the joints alleviated by warmth and aggravated by cold without local redness, as what you can see among patients who have osteoarthritis. Also, it's painful or cold impediment where the disease has severe joint pain exaggerated by cold. So if you ask osteoarthritic patients, they would say that it usually happens in the morning, especially when there is the cold weather. Or it is a fixed or dampness impediment, which is also a definition for the traditional Chinese medicine. So we went about it and tried to look into what acupuncture can do. And so we know that acupuncture indeed has some effect on certain modalities, certain aspects of illness. And it has been proven to be effective in relieving osteoarthritis symptoms, particularly on this point. So we have 1, 2, 3, 4, as defined by another investigator. But we were not satisfied to just do it on 4 points. So we looked again into the traditional Chinese medicine points, and we came out with 10 points. Why did we do this? Because we know that Filipinos are very much afraid of needles. When they are shown the needle, they are very squirm. Unlike Chinese people are used to acupuncture. So when you show them the needle, it's a welcomed modality for them. But among Filipinos, when you show the needle, they squirm already, so they don't want it. So we said that Filipinos also would need, we now have a license that is imposed by the government to practice acupuncture. So we have to go through the Philippine Institute for Traditional and Alternative Healthcare, which is PITAC, okay? So why not combine laser therapy and acupuncture for the treatment and management of osteoarthritis of the knees among Filipinos? Because we were saying that we would be able to combine the benefits of laser therapy and the benefits of acupuncture, okay? So our objective was to show that the laser treatment on acupoints, we have selected certain acupoints, can control the manifestations of osteoarthritis. And these were our variables: pain, joint stiffness, range of motion, mobility. And of course, we have to see how regular and what are the dose of analgesic intake, just in case that they have what you call the sudden burst of pain, okay? And so we did a quantitative experimental design where randomized control trial where there was group E, and group E was given the therapy, while group C was the control, and they did not receive the laser therapy. So this was the pre-test, the pre-treatment, the during treatment, and the post-treatment. So the pre-treatment, we compare both for the experimental group and the control group. And there was no difference among them. And so these are our inclusion criteria. They must be at least 40 to 7 years old, cognitively able to follow instructions, because there were some instructions, mentally alert, suffering from osteoarthritis for at least 6 months, okay? And the inclusion criteria also, osteoarthritis mainly felt on the knees. We did not include other manifestations from the shoulder or from the arms. We were just trying to put it locally on the knees so that it will be easier to monitor and to look into it. So our another inclusion was minimal to moderate, as per we were using the American Rheumatology Association criteria, which was also equivalent to a Chinese diagnosis. Our exclusion criteria, there should be no extreme deformity of the knees and osteoarthritis from different parts of the body, and lesions over acupoints, like they also have cancer, malignant tumors, or even varicosities of the lower extremities. So we excluded them. And also other comorbidities, like if they have epilepsy, renal and heart disease, uncontrolled diabetes, or they were undergoing uninterrupted rehabilitation measures because it would definitely affect the results that we wanted. So our sample population was 170 divided into 85 control and 85 experimental. So we used a 800 power. This is all very statistical, one-tailed at alpha 0.05. And then the distribution was random by blinded into two groups, the experimental and the control. So the physicians who applied the laser were different from the person who was trying to come up with the measurement of the variables. Next, please. So this was the procedure. The research was done to determine acupuncture points. And then the proposal was submitted to the ethics. Remember, in our country, you always have to have an ethics review. And then the proposal was submitted to a funding agency, which was the Philippine Institute for Traditional and Alternative Healthcare. Okay. And subjects were examined, enrolled in a study. And mental competence examination were also done for patients 65 to 70, utilizing the A2 capacity evaluation, which we got from another author. Okay, so a pre-test on 4 subjects. So before we even did it on the actual subjects, we had to do it on 4 subjects so that we will have the ability to perfect the procedure. So we did it in January with 4 subjects, 2 for the control and 2 for the experimental, before we plunged into the research proper, which was February up to November of last year. And then, so we had 5 days pre-test, 5 days during, and 5 days post-test. So data was analyzed through a social package, statistical package. So the equipment we were using is the one that you see outside. It is low-level laser matrix therapeutic apparatus with a wavelength of 8.808, which is infrared. The application was 200 milliwatts, 30 seconds on each acupoint for a frequency of 200 hertz. And these were the points that we used. These are very traditional Chinese medicine acupuncture points, where we included the one that we got from the literature and the one that was recommended also from various authors. Okay, thank you. And the variable measurement were pain score, where it was measured by visual analog scale, and where you can see from 0, no pain, to 10, severe pain. And then we had joint stiffness in minutes as duration of morning stiffness, because osteoarthritic patients, when they wake up, occasionally they will not be able to move their joints. And it was measured in the number of minutes that we're able to move it. And of course, the range of motion, and then the mobility through functional independent measurement, utilizing a 30-second chair stand. So the patient would be asked to sit on a chair and then stand up, sit and stand up, and counted for a duration of 30 seconds, okay? And then we have also the analgesic intake of paracetamol, 500 grams, as rescue dose for breakthrough pain. Just in case that the patient would have the pain, we gave them paracetamol 500. So what was done? The analysis was done by using statistical package of the latest is 22, and of course it used statistical analysis using t-test, independent and paired t-test, at comparing the experimental and the control groups. And what did we see for the demographics? We have the experimental group. There were 14 males. There were 71 females. For the control group, there were 18 males, 67 females, and for a total of 170. And this is the age and duration of the osteoarthritis. You would notice that there is no significant difference. So we can entirely say that the matching of the experimental and the control group was okay because there was no difference before the start of the research. And the scores, we did a day-to-day analysis, showed significant differences between the experimental and the control with high effect sizes, meaning the magnitude of the effect at 0.01, significant alpha, especially on day 6, and particularly going up to day 15. And of course, we also did the comparison between the groups, the control and the experimental, on the pre-test, the during, and the post-test. And we saw that clinical improvement really showed on the 3rd day of laser application, which was day 8. So from the graph, this is now the line graph on the VAS scores. The VAS scores, remember, shows the intensity of the pain. So the blue one shows the experimental group, and the yellow one shows the control group. So you can particularly notice the downward trend of the experimental group, while the control group was just horizontally linear. Okay? And then we also did for the joint stiffness. Remember, we had several variables. And so the day-to-day analysis showed significant changes from day 8. So that was the 3rd day after the treatment of the laser. And indeed, the effect size was very much higher compared to the 2 groups. Next. And we also did the 5-day as usual, like the VAS. And it was shown that the graph, next one, the graph here. So you would notice that this is the experimental, and that is the control. And as usual, the control is showing a horizontal linear pattern, while the experimental group was showing a constantly dropping measure for joint stiffness. So that means that the joint stiffness of the experimental group was getting lesser and lesser as the day went on. So how about the range of motion? The range of motion, because we also enrolled patients with only one leg, so either the left leg or the left leg, or they also had patients with both knees affected. So we were analyzing it according to the side of the knees that were affected. And the subjects with unilateral, either left or right, and bilateral, were enrolled in this study. This is what can be shown here. The left, there were about 11. The right, there were about 10, distributed according to male and female. And the bilateral were the majority at 149, for a total of 170 subjects. Okay. So on the day-to-day analysis, there seemed to be no significant difference between the control and the experimental. However, the means of the experimental group seems to increase. So there was more range of motion for the experimental group. We used a goniometer. It's a particular kind of ruler that rehab medical specialists would use to measure the range of motion of the knee. So they measure it here. Although there was no significant differences, it looked like that the means of the experimental group were really better, as you can see. So in the same way as it was, and with the comparison between the control and the experimental, during the treatment and post-treatment phase, there was a significant difference. So if it was day-to-day, there seemed to be no difference. But comparing the groups, there was a difference between the two. And we can see particularly with the graph, okay? So As the graph for the experimental was going up, again, the control group was very much in a linear pattern. And finally, we also have the right knee. It is also the same. The right and the left were the same. So it's the same. Can I go to the next one? Look, so this is for the right knee. And again, the pattern for the control was very, very linear. So it really shows a difference between the control and the experimental. So finally, we go to the mobility. So the mobility, where you do the exercises, remember? And it showed that the differences between the experimental and the control came after day or from day 10 onwards, almost the end of the treatment and almost the start of the post-treatment process. On day-to-day, there were significant differences at the post-treatment phase. So it did not show during or pre-treatment, but only post-treatment phase. So this is the line graph. You can see the improvement again of the experimental group, while the control had, again, a horizontal pattern. How about for analgesic intake? Well, most of the patients did not take their rescue dosage because they said they can tolerate it, so they did not do it. But the graph would show that the experimental had lesser. But these are only some patients for the control. So we did not do any statistical analysis for that because there are only 1 or 2. But you can still see that. So in conclusion, we say that the low-level laser therapy can indeed diminish the manifestations of osteoarthritis of the knees. And we can now say that we can use it for our Filipino patients using a certain regimen because many are suffering from osteoarthritis and most of them cannot really afford to have their maintenance, aside from the fact that we subject them to more destroying drugs. So we recommend that the LLT can really be used. We can only, the only thing is they can just overcome the initial fear, because when we were starting it way back in February, the question was, are they going to get burned? So the recruitment was quite slow at the time. Are we going to get burned? Not because they were talking about radiation, we're talking about laser. So their bias was more on laser. They said when you say laser, you know, the thing that they used. So they say that it can burn. But after the initial phase, we were very happy that they had relief of their knees. We had a party in December because we finished it in November, and most of our patients were able to dance with us. So can you imagine giving comfort to most of our patients? Okay, so these are our reference, and so on and so forth. And thank you for listening.